This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the 2026 edition of BMJ Open. It's a protocol trial that addresses one of the most common yet debated aspects of our daily practice.
That's right. We are discussing the SUPERDURA trial. The full title is Active Subperiosteal versus Passive Subdural 24-hour Drainage Following Single Burr Hole Evacuation of Chronic Subdural Hematoma. It's a multicenter, randomized, non-inferiority trial.
It's interesting, Dr. Aris, because even though chronic subdural hematoma, or CSSDH, is one of the bread and butter cases in neurosurgery, our techniques for drainage still vary wildly between institutions. We know from the landmark Subperiosteal trial years ago that drainage in general reduces recurrence, but the where and the how are still up for grabs.
Exactly. This protocol targets that exact gray area. For the students and residents listening, remember that for a long time, the gold standard was a subdural drain. But putting a tube directly into the subdural space carries risks, parenchymal injury, infection, or triggering seizures. The SUPERDURA trial is testing whether a subperiosteal drain, which sits outside the dura, is non-inferior to the classic subdural approach.
And specifically, they are looking at active subperiosteal drainage versus passive subdural drainage. Let's dive into the protocol specifics. The study focuses on patients undergoing a single burr hole evacuation. That's a key point, isn't it?
It is. Many surgeons prefer two burr holes, but the trend is moving towards single burr hole surgery to minimize operative time and trauma, provided the evacuation is thorough. By standardizing to a single burr hole, the SUPERDURA investigators are removing a significant variable. Ilara, walk us through the two arms of the trial.
Of course. In Arm A, we have the active subperiosteal drain. After the hematoma is evacuated and the dura is closed or left open, depending on the specific surgical nuance, the drain is placed in the subperiosteal space, under the gala, and attached to a suction bulb to create active negative pressure.
And Arm B?
That's the passive subdural drain. The drain is placed directly into the subdural space, but instead of suction, it relies on gravity or simple closed system drainage without active negative pressure. In both arms, the protocol specifies a 24-hour duration for the drain.
That 24-hour mark is crucial. We often see drains left in for 48 or even 72 hours in some centers, which increases the risk of surgical site infections. By limiting it to 24 hours, the trial is pushing for a more efficient, potentially safer postoperative course. Now, why a non-inferiority design?
That's a great question for our residents. The researchers aren't necessarily trying to prove that subperiosteal drainage is better at preventing recurrence. They are trying to prove it is not significantly worse. If they can show it's non-inferior in terms of recurrence rates, then the secondary benefits, like a lower risk of brain tissue injury, make the subperiosteal approach the more attractive option.
Right. If the recurrence rate is roughly the same, but I don't have to worry about a silicone tube poking the motor cortex, I'm going to choose the subperiosteal space every time. What are the primary endpoints they're looking at in the protocol?
The primary outcome is the recurrence of symptomatic CSSDH requiring reoperation within 6 months. This is the hard endpoint that matters most to patients and surgeons.
And for our practicing colleagues, the secondary endpoints are equally vital. They're looking at the rate of postoperative complications, specifically infections like empyema or meningitis, and the incidence of new-onset seizures. There's also the length of hospital stay and functional outcomes using the modified Rankin scale.
One detail in the SUPERDURA protocol that caught my eye was the focus on the active component of the subperiosteal drain. In some previous studies, subperiosteal drains were passive. Why do you think they're insisting on suction for the subperiosteal arm, Dr. Aris?
It's about dead space. When you place a drain outside the dura, you're relying on that suction to pull the underlying fluid out through the burr hole and encourage the brain to re-expand against the skull. Without suction, a subperiosteal drain might not be as effective at clearing the residual subdural collection compared to a drain that's sitting right in the fluid.
That makes sense. It's essentially a bridge. The suction compensates for the fact that the drain isn't in direct contact with the entire hematoma cavity.
Exactly. Now, let's talk about the patient population. CSSDH is a disease of the elderly. These patients are often on anticoagulants or antiplatelets. Does the protocol address that?
It does. The trial includes patients with both primary and recurrent CSSDH, but the protocol emphasizes a standardized approach to restarting anticoagulants. This is always a headache in the ward, balancing the risk of a new stroke against the risk of the hematoma coming back. By having a multicenter, randomized approach, SUPERDURA should give us more robust data than the single-center retrospective series we've relied on in the past.
I also noticed they are using a single burr hole technique.
For the residents listening, when you're in the OR, where you place that burr hole matters. Usually, it's over the thickest part of the collection. If the trial proves that a single burr hole with a 24-hour subperiosteal drain is effective, it could really simplify our surgical workflow.
And it could reduce the surgical footprint. If we can achieve the same results with less invasive maneuvers, it's a win for the patient. The SUPERDURA protocol also mentions that the surgeons have to be experienced. There's a bit of a lead-in period to ensure the technique is standardized across all the participating centers.
That's important for the validity of a multicenter trial. You don't want the results skewed because one center is better at burr holes than another. Now, Ilara, what's the projected timeline? This is the protocol paper, so when do we expect the final data?
Given the 2026 publication of the protocol and the 6-month follow-up required for the primary endpoint, we are likely looking at a couple of years for recruitment and data maturation. But the fact that it's a multicenter study means recruitment should be brisk. CSSDH is certainly not a rare condition.
No, it's often called the coming epidemic in neurosurgery because of our aging population.
One final thing to note for our listeners interested in trial design, the non-inferiority margin. The researchers have to set a limit, a percentage by which the subperiosteal arm can be worse than the subdural arm and still be considered non-inferior. It's a delicate statistical balance. If the margin is too wide, the trial is meaningless. Too narrow, and you need a massive number of patients.
It's a tough balance, but the SUPERDURA trial seems well-powered to give us a definitive answer. For the residents, I think the takeaway here is to watch this space. We might be moving away from subdural drains entirely in the next 5 years.
It's a shift towards safety without sacrificing efficacy. If I'm a patient, I definitely prefer the drain that stays away from my brain tissue.
Well said. I think that covers the core of the SUPERDURA protocol. It's a pragmatic, clinically relevant study that addresses a daily question in the neurosurgical ward. Where does the drain go, and how long does it stay?
And for our listeners, the paper is titled The SUPERDURA Trial in BMJ Open 2026. It's a great read if you want to see how a high-quality neurosurgical trial is structured.
Thanks for joining me today, Ilara.
Always a pleasure, Dr. Aris.
To our listeners, stay sharp, keep reading, and we'll see you in the next episode of the Neurosurgery Hub podcast.
Goodbye, everyone.